7, 6, 5, 4, 3, 2, 1.
Hi, everyone. We are going to begin this amazing webinar sponsored by DK Medtech. We're going to talk about our passion, vascular access. The main purpose is to talk about is high pressure POBA real enough? We're going to have many specialists around the world. We're going to have Matteo Tozzi from Italy. We're going to have Jack Ho from Singapore, Leonardo Harduin from Brazil, and me, Marcio Filippo, from Brazil, Rio de Janeiro. The first presentation is going to be the science of scoring decutting versus POBA in dialysis access of Matteo Tozzi.
Hi, everyone. Thank you, Marcio, for the presentation. Thank you to DK Med for this amazing meeting about the new vision for vessel preparation and treatment of the stenosis in the vascular arches. So with my presentation, I can describe the problem about the word of neointimal hyperplasia. Next, please. My disclosure, next. So the problem today is use or not use the POBA for the predilatation or for the treatment of the stenosis in failing vascular arches, native or graft. Next. So from the pathophysiology point of view, the neointimal hyperplasia is a very complex phenomenon. It's based on two different group of events upstream, for example, the surgical damage of the changement on the flow inside the vein. This changement start after the clamping the vessel, so very precox, and then start all the process that finished with the negative evolution of the fistula with a stenosis. The downstream events is all the events, the cellular events that start from the proliferation of fibroblast and the production of matrix in a very inflammatory ambient. Next. We have today a lot of different type of methodology for study the flow inside the fistula, native fistula or graft arches. Two area is the really Achilles heels of these vascular arches, the diastonotic area in the native, and on the right, screen in the graft vein anastomosis, the point for our treatment in 99 of our patients. Next. From the anatomical point of view, I revise my 10-year experience with different type of scoring, high pressure, and DCB. And I classify next the lesion in native fistula and in graft in 3 different moments of the same process of evolution of the intimal hyperplasia. Next. If you see type 1, 2, or 3 are not the different type of stenosis, but it's the same stenosis with the evolution during the time. Type 1, de novo lesion, is possible to see on duplex ultrasound the intimal hyperplasia more than 1.5 millimeter. The type 2 probably is the end of this process, starting with the fibrosis of the adventitia and the lumen of the vessel collapse. The type 3 is a mix of the two. The interval time from starting the intimal hyperplasia, the novo lesion, to the end of this process when the vessel is completely collapsed without a correct lumen. Next. A very little specimen of an intimal hyperplasia in a native arches show us 2 different areas. The luminal part with high fibrosis tissue and low number of cells. In the deeper part, another different pathway with high number of cells in active replication and inactive production of matrix. Next. The architecture of the intimal hyperplasia is very complex. We see a lot of vessel in the cellular part of the intimal hyperplasia. Next. With electron microscopy, it's possible to show the fiber of collagen in the red part. We show all the collagen in a stenosis in a graft. Is the deeper part of the lesion, and the upper part is fibrosis, thrombus, and the low number of cell. Next. And if we mark the area of lesion, for example, in this type of graft, in the luminal part we have a very hard fibrosis area, in the deeper part area with cell in active replication and producing the collagen for the fibrosis area. Next. What is our result today? This is the probably most famous paper published in New England Journal of Medicine in 2024, the publication of Impact AVHs, that showed the role of DCB. But for us, it's very important see the result of POBA at 6 months. The result of POBA in terms of target lesion primary patency is lower 70%. And naturally, at 1 year is average 50%. Next. So the use of POBA allows a very frequent procedure of our patients. And in in light of this concept about the hard fibrosis area in the stenosis of the vascular access stenus, why do we need an high pressure scoring? Next. For this reason, on the left we showed an IBUS with a standard scoring balloon with floating element around, and the right we see the treatment with triangular and fixed element with the cutting balloon. So if you show our the uniformity of the dilatation is one of the strong characteristics of the use with this balloon. Next. Today we have different paper showing us the strength of the cutting balloon. This published last year in renal failure with a lot of very big cohort of patients treated with the cutting in association with high pressure or only the cutting. Next. So a 6-month right vascular arches, prosthetic vascular arch, red AV fistula, 6-month result of the treatment with the cutting balloon showed us a percentage of primary patency more than 75% of overall. So a very perfect result with this type of predilatation. The combination of high pressure with a fixed element, triangular element, is the key of this type of treatment. Next. The author classify the result also based on the number of previous intervention. In our practice, we know very well that the patients with previous a lot of retreatment, the free time from stenosis is very less. But if you show more than 5 treatment in graft or in native with the use of the cutting balloon, the result is more than 70% and 87% in the graft. So this is underline the balloon efficacy also in complex case, not only in the treatment of de novo lesion. Next. Can we improve this amazing result with the use of the cutting balloon? Next, in my mind, my answer is yes. Next, please. Because it's possible to perform a combination of a perfect mechanical dilatation with the cutting balloon in combination with drugs, antiproliferative drugs like paclitaxel. So with apply after a correct vessel predilatation a DCB. Next. Next, please. If we show the last publication in European Journal of Vascular Surgery, these authors, the group of writing the next guide for the vascular access, publish this meta-analysis. Next, that show the role of DCB in the treatment of the vascular access. Next, please. If you show more than 14 paper showed a good odds ratio, and naturally all this work underline the role in favor of paclitaxel-coated balloon in the treatment of the vascular arches in different anatomical area, outflow, cephalic arch, juxtaanastomotic area. So today we have a very high level of evidence about the use of DCB in combination of a correct predilatation. Why? Because the cellular part of our stenosis in the deeper part of the stenosis, so is mandatory to perform a perfect preparation of the vessel, and with the cutting balloon today is possible. Next, please. The conclusion we see underlying the role of paclitaxel after a correct predilatation of the vessel. Next, please. This is one of our case in a graft with terrible lesion inside the graft, and normally the lesion, the stenosis inside the graft is very hard to perform a predilatation, but with 640 the cutting balloon with 3 different time dilatation, the graft come back perfectly, and I treat the single lesion with 3 different drug-coated balloon. Next, please. Thank you so much for your attention, and we discuss all together.
Congratulations for your presentation, Dr. Matteo Tozzi. And we're going to move with the presentation of Leonardo Harduin, technical tips on inflammation, sizing, and safety. No sound, Leo. No sound. You have to activate the sound, please.
Now it's okay.
Okay.
Now it's okay. Okay, perfect.
Good.
Sorry, guys. So good morning for Brazilian guys, good afternoon for the European guys, and good evening for the Asian guys. So it's a pleasure to be here. Thank you very much for the invitation, and thanks for the CAT to organize for the organization for about this meeting. And my presentation today it's about technical tips on inflation, sizing, and safety. Next, please. Next. Thank you very much. My disclosure. Next, please. So, end-stage kidney disease is a huge problem worldwide that it bring a huge impact in the healthcare system. And in Brazil is not different. Nowadays we have more than 107,000 patients that depends on hemodialysis here in our country. According to the guidelines, we know that arteriovenous fistula and grafts are the best vascular access because they are associated with better patency and with improvements considering mortality and complications in vascular access. But of course, fistula is not a perfect access, and it's so common to have high rates of dysfunction. In general, after 18 months, around 40% of the fistulas will have problems with patency. Next, please. This problem used to have a huge association with intimal hyperplasia and stenosis that can happen in different parts of the circuit, as we can see in the left image. Next, please. According to the guidelines, mainly according to the CADOC guidelines, the balloon angioplasty still is considered the standard of care for the treatment of the vascular access stenosis, vascular access lesion. However, we know that after the angioplasty, after the procedure, the stenosis rates used to be very high when we are using just POBA. And after 12 months, the recurrence rates are very high, and nearly 70% of the patients used to have a kind of recurrence until 1 year after 1 year, after 1 year of the treatment. Next, please. It's so important to know that this high rate of recurrence in vascular access is associated with a multifactorial problems. The more important problems is the intimal hyperplasia, because most of the lesions in the vascular access are associated with intimal hyperplasia in the physiopathology. Next, please. Another important point is the characteristics of the lesions. In vascular access, in general, we don't have only one kind of lesions, one kind of physiopathology that bring the lesions in the all part of the circuit. It was demonstrated in this important article. Here we can see the four main kinds of lesions that we can see in the vascular access. In the image a typical lesion with intimal hyperplasia physiopathology. In image B, we have a stenosis that's happening because a kind of fibrosis, like a external compression. In the image C, a stenosis related with a valve, and the image D, a stenosis related with a calcification that used to happen in all the access. Of course, these different kind of physiopathology need to be addressed with different kinds of technology to achieve better results. Next, please. Another important point when we are making vascular access intervention is to understand the location of stenosis, the stenosis location, and the physiopathology in each kind of part of the circuit. We have three main lesions that are the inflow lesions, the outflow lesions, and the central venous lesions. In the inflow lesions, the juxtanesomotic stenosis it's most frequent. In the outflow lesion, we used to have cephalic artery stenosis and basilic swing point stenosis. In the AVG lesions, we have the venous graft anastomosis stenosis. And in central venous, we have a kind of mix of problems with a compression and inflammation. Different type of lesions, different lesion locations are associated with different physiopathologies. And of course, we need to have different technologies, different approaches to achieve better results. Next. And when we are doing vascular access intervention, of course, we need to think what is the best way to improve our results. And now in the next few slides, I will try to give some information to achieve better results in vascular access interventions. Next. The first point, the first modifiable technique that we can use it during our interventional procedures, it's about the inflation pressure of the balloons. Here we can see a classic paper that was published by Scott Terotola that brings us information about normal pressure, low pressure, high pressure, and ultra high pressure. In general, conventional balloons with a low pressure used to be inadequate for the treatment of vascular access stenosis because these lesions used to be so fibrotic, so rigid, and in general resistant a low pressure, a normal PTA. And normally we need a high pressure or very high pressure to treat the vascular access stenosis in all parts of the circuit. Next. These findings, these data were confirmed in this other paper, so interesting paper published by Professor Kitru 2 years ago. It was a sub-analysis from the Electronics Global Registry that showed us, that demonstrated that the group of patients that was treated with ultra high pressure vessel preparation presented better results compared with the group of patients that was treated just with a low pressure balloon angioplasty. Next, please. And it was so interesting because this year we presented during the SAVE Symposium just a few minutes ago, very similar results during our Lutonix, our SAVE LTC registry. We compared the two groups of patients that were treated with DCB. The first group of patients received a pre-dilation, a vessel preparation with a high pressure balloon and with more than 25 atm of pressure. And the second group received a normal pressure during the angioplasty. And the final endpoint was 12-month results, and the patients' 12-month target lesion primary plate rates, and the group of patients that were treated with a high pressure balloon demonstrated statistically better results. Next. Another interesting paper that had a so similar conclusion. They compared the patients treated with a high pressure balloon versus low pressure balloon. And two important points in this study. First of all, the technical success was statistically higher in the group of patients that was used the high pressure balloon. Next. And the target lesion primary patency also was statistically higher in the group of patients treated with a high pressure balloon. So, important conclusion that we have considered the inflation pressure is the inflation pressure, a high inflation pressures can improve the technical success and the target lesion primary patency rate. So the recommendation nowadays is always, whatever is possible, to use a high pressure balloon with a high inflation pressure during the procedures. Next. Another important point, another modifier point during our procedures is the balloon sizing. This paper from the interventional cardiology from the coronary angioplasty showed that when the authors used oversized in the coronary angioplasty, the results were better considering the technical success, considering the raised stenotic lesions, and considering the residual stenosis compared to the undersized group versus oversized group. The point is, next please, it's possible to reproduce the result from the interventional cardiology using the oversized balloon in the vascular access environment. Yes, the answer is yes. And some papers demonstrated exactly this. In this interesting study, the authors compared the patients that was submitted procedures to angioplasties in vascular access with vascular access stenosis. Two different groups: patients with success. The success was classified as less than 30% of residual stenosis, and the group without success. So the authors conclude that the group of patients that received the angioplasty with larger balloons and with scoring balloons presented statistically better results than the group with normal sized or undersized balloons. Next. And the use of high pressure balloons with oversized impacted in the final results in the primary patency at 12 months. Next. This paper had the same conclusion when the patients were treated with a large diameter balloon, more than 5 millimeters or less than 5 millimeters. The results in the multivariated analysis showed that patients with a larger balloons presented better patency. Next. Larger balloon also improved the vascular access resistance and flow according to this retrospective analysis compared with a normal sized balloons or undersized balloons. Next. Even when we are doing vascular access maturation, the BAM, the balloon assisted maturation, this is a so interesting paper from our SAVE group using the largest balloons to induce the maturation. Here we can see that the technical success was so similar compared with other papers that used just undersized or normal size endoplasty. Next. Our suggestion was to use 80 millimeters, 9 millimeters, or 10 millimeters balloons, so large size balloons, yeah, to induce the vascular access maturation. Next. Important conclusion from this paper, from our experience, was the complication rates were so similar compared with other papers that just used normal size balloons. Next. But the important point was the time to use the fistula and the time of catheter dependence. Yeah? In our experience, using large size balloons, we can allow the AVF puncture with less time compared with other papers. Our average was 5 days using large balloons against an average 4 or 5 weeks when we analyze the data from other papers. Next. And it was so interesting because other experts reproduced the same results with the same technique, early puncture of the fistulas without high rates of complication using large balloons to induce the maturation. Next. A so interesting analysis that from a sub-analysis of the IMPACT-AV trial was the results comparing large balloons, more than 7 millimeters high pressure balloons, versus normal size or undersized balloon that was considered less than 7 millimeters PTA. Here we can see in the image from the right that the patients that was treated with a 7 millimeters, 8 millimeters, or 9 millimeters balloon presented better results compared with the patients that received treatment with balloons with a small diameter. So it's so important, this sub-analysis, because it showed us in a control trial, the authors demonstrated the same results, maybe a benefit with the use of large balloons during the vascular access interventions. Next. Another important point is the inflation time. Despite the guidelines suggest that there is no recommendation about the inflation time, we found some interesting papers talking about this. This publication compared the 1 minute inflation time versus 3 minutes inflation time and no difference considering the technical success or the patency was found. But next, please. This other paper make the same methodology, compared here 30 seconds inflation versus 1 minute inflation time, and the result was so interesting. Patients that was treated with 30 seconds inflation time presented statistically better patency at 6 months. Next. This randomized control trial compared 0 second inflation versus 30 seconds inflation, and also saw encouraging results, saw interesting results. The group of patients treated with 30 seconds inflation time presented statistically better results. And another important finding in this paper was about the pressure that was used during the angioplasty. When the authors increased the pressure of the balloon, the result was statistically better. Next. Of course, when we are treating different lesions, we need different technology to address a mechanical angioplasty, a better angioplasty, mainly when we are thinking about anti-proliferative technology. And nowadays, a lot of experts are suggesting a new kind of angioplasty with the scoring balloons, and so interesting results were published. Here, we can see the paper published by Dr. John Ross using a scoring balloon. Next, please. And the target lesion primary patency rate at 6 months was around 80%. And it is encouraging results with this new technology, because if we compare the result from the scoring balloons studies with the DCB studies, we can see that the result from the scoring balloon used to be so similar even without anti-proliferative drugs. Next. The same findings were reproduced with for these authors. I think that Dr. Tozzi presented the results, something around 80% of patency at 6 months. Amazing results, so similar results if we think about anti-proliferative technology, if we think about DCB trials. Next. Just some take-home messages. High-pressure balloons improve technical success and patency. It is mandatory to use this kind of technology in the vascular access intervention. Maybe 30-second inflation times appear to be associated with better outcomes. Balloon oversizing may be associated with a greater luminal gain and improve access survival and technical success. And dedicated scoring balloon may be a game changer in vascular access intervention. Next. Thank you very much, guys, for your attention.
Congratulations for your presentation, Leonardo. Very nice. We're going to have some minutes of discussion. If anyone in the audience wants to make a question, there is a Q&A button, question answer button in below. You can make any question. We're going to answer you. So I have a question for the panelists. So in your opinion, what is the first choice of treatment in the vascular access? To use high pressure balloon only, scoring balloon only, high pressure balloon plus drug coated balloon? What is your first choice now?
I don't know.
Please,
is
Matteo,
very
go ahead.
is very different, is very complex to answer. But I think high pressure scoring today is two key point in our practice for just a vessel preparation or for final treatment. I, in my practice, I definitely use scoring balloon for stenosis in graft venous anastomosis, or in arterial graft anastomosis, because it's most harder to perform a correct predilatation, also with an high pressure in graft. Naturally, most of our fistula, for example, a native fistula at wrist, probably an high pressure balloon is correct.
So in native fistula, in just anastomotic or puncture area, what is the first choice for you in this case?
Yeah, Marcio, maybe I'd like to take this question. Actually, I feel that, of course, we also really have to see the anatomy or the features of the stenosis, as Matteo and Leonardo mentioned. I think ultrasound is very, very good assessment. And then if it is a relatively homogeneous thickening of the intima, I think either high pressure balloon or the scoring balloon will be an option. You mentioned that if it is the cannulation area, I feel that over the cannulation area, there is a lot of scars forming. So my concept is usually I will use those that balloon that can be focal high pressure. It's either scoring balloon or peripheral cutting balloon. I think those are good options. But most importantly, after the balloon angioplasty, we have to instruct the dialysis nurses that not to needle the same area again and not to repeat the same causes to induce those injury. So I think those are very important. And in my current practice, I will be more using scoring balloon or the peripheral cutting balloon. Scoring is mainly for a longer lesion. And of course, not only on the longer lesion, but I think for the short lesion, both scoring and peripheral cutting balloon are performing, both are performing quite well.
Do you want to say something, Leonardo?
Yeah, I think it's a so interesting question, Marcio, about the better device to use during the vascular access procedures. Until some months ago, yeah, because now we have the possibility to use this new technology that puts together scoring balloons and high pressure balloons. But until a few months ago, my preference is always to use a high pressure balloons because the lesions in vascular access used to be a so resistant lesions. But when we can put together this new technology, I think that we can find a balance between a high pressure and mechanic angioplasty or mechanic vessel preparation when you are thinking about a DCB, yeah. And maybe using the decutting, we can have a better results without the use of rated pressures of the balloon. So another important point is when we do the comparison between the result from scoring balloons studies and the result from the DCB trials, even without anti-proliferative technology, the results are so similar. It's unbelievable. And I would like to do the question for the panelists. Do you have any idea about the reason for this? Because we know that vascular access is a multifactorial angioplasty, multifactorial physiopathology, and the scoring balloons don't address the antiproliferative problem. Yeah, and even without this antiproliferative technology, the results are being amazing. What is the reason for this?
Sorry, Leonardo, I think the participant has a lot of questions for you.
Okay.
I want to make one short commentary about this. I think that the key point in the scoring balloon, Leo, is that the aggression to the wall is not so high as in the high pressure balloon. High pressure balloons sometimes explode the vein, and the lesion in the scoring balloon is more controlled. So the neointimal hyperplasia probably is less, so you don't need so much the paclitaxel sirolimus as when you use the high pressure balloon. But it's just a hypothesis. I can't confirm this. And
Yeah.
I want to move on and just show, let's answer the questions of the audience. The first question is from Jimmy from Singapore. How do you balance oversizing from luminal gain with the potential for vessel injury with oversize? How does one define oversizing?
Yeah, it's a so interesting question. Yeah, amazing question. It's difficult nowadays define oversizing. Yeah, we don't have a formal definition in the guidelines about oversizing, but I believe that when you are using a balloon that is larger than the vessel, yeah, I think that we can define this as oversize. And to find the balance about oversize and the risk of rupture, it's difficult. Yeah. When we are talking about oversizing in balloon-assisted maturation, I think that there is some technical points as to have a open outflow to use a free oversize as we suggested in our paper. But in the normal angioplasty, in the normal procedure, in a matured fistula with stenosis, in one of the article that I presented, the author suggests that something around 10 or 20% of oversize to have a good balance between good results and lower risk of rupture.
We have another one question, so let's anyone else to answer this. How can we tailor our interventions based on lesion characteristics on ultrasound? Some lesions are due to neointimal hyperplasia, some are due to extrinsic scarring. If you see neointimal hyperplasia, are you more keen to do scoring balloon? Jack Ho or Matteo that time?
Yeah, I think Dr. Sumisu has a paper, a very nice study, comparing two groups of lesion. One having intimal hyperplasia and one really a scarring of the blood vessels so that the wall is really very thin and the lumen is very small. So in his paper, the difference that he shows is actually those that with a scarring type of lesion, they are more responsive to the drug-coated balloon. So I think that is number one. These different pathologies, they respond differently to, I think, both the preparation as well as the drug that being used. Of course, this is a very nice paper, but I don't think we have all the answers to exactly which type of the lesion will be more responsive to drug. And also, to complicate the picture more, there is more than one drugs available right now. Apart from paclitaxel, there is also sirolimus. So I think that remain to be a big question for us to find answers and understand more. The second thought is if you do see on the ultrasound that it is a scarring type of lesion. In fact, this kind of lesion, I feel that there is a slightly higher chance of rupture if you are using it maybe purely using the high pressure or using a much oversized balloons. So this kind of lesion, I will be more cautious. Yeah.
Let's
I
try to
agree. I agree with Jackie. Probably our main goal in the future is try the different anatomy, the different feature of single stenosis by duplex ultrasound to apply scoring and then sirolimus or paclitaxel or just an high pressure. This is the problem in the literature, why each different study present different result, because we treat all type of different stenosis with the same balloon. This is the problem today.
Yeah, exactly.
not
Same
only
balloon and same
not
same balloon and same technology for all the lesions. Yeah,
yeah,
we
that's
don't
the
Yes.
have
point.
this. Yeah, exactly.
Not
Yeah,
only the
they.
type, the characteristic, and also the location. Many different
Yes.
locations with the same. They
Yeah.
don't be.
If
The behavior is
the,
different.
the cephalic arch is not similar to the just anastomotic area, yes,
Exactly. Exactly. Yeah.
Totally
That's the
agree.
point.
Totally agree.
is the
Can
same.
can we move?
The anatomy
Sorry,
is completely different.
we have a lot of questions. Let's try to answer all of them. Sorry.
Okay.
Let's try to be quick in the answers, please. The other answer is from Mihai Kuku. Sorry if I didn't say properly. I use 6 millimeter ultra high pressure balloon in the forearm. Should I up the game to a 7 millimeter for better results?
Probably. Yeah. I am a defensor of the oversized balloon angioplasty. Yeah, and my feeling is when we use a oversized and yeah, I think that we have a luminal gain, we have a better flow, and we have a better patency. Yeah, because using oversizing and using a ultra high pressure balloons, my feeling is that you can break the fibrotic lesions. Yeah, and we can make some kind of chance in the environment in this specific place, and maybe we can uh, increase the period of time between the intervention. So my recommendation is to use it even if we are treating a forearm stenosis, to use or maybe 7, 8, or sometimes 9 millimeters high pressure balloons.
There is another point, Leo. Many patients, I do the ultrasound 1 week after the procedure. And in many cases, I can see a decrease in 1 or even 2 millimeters
Exactly,
of,
exactly, exactly.
of the
It's
angioplasty
a,
site. So
it's a,
if you use a 6, when the patient come
yeah,
back,
5 millimeters 1 week before.
uh,
Yeah,
probably if we wait 1 hour to do a final control 1 hour after the dilation, probably you will see the decrease, but we don't have time to wait for this. I do that when the patient come back in my office and I see this 1 or 2 millimeters. So if you are treating a 6 millimeter area vessel, probably if you use a 6 when the patient come back will be 5 or 4. So in my opinion, it's a good idea to use a balloon 1 or 2 millimeters bigger than the vessel.
Actually, can
Another
perfect.
I
question.
Yes.
supplement? Like, I found that it's very interesting about sizing because when we learn sizing, it's mainly learned from peripheral arterial disease. So usually we will very seldom use a balloon that is like much bigger size than the peripheral artery because the artery, the wall structure as well as the disease is very different from dialysis access. So dialysis access is never artery. It's all usually is the venous side, but it's an arterialized vein. So actually, I think we really don't have real answer like how to gauge the size. And I think that is another like very interesting research study to understand more how these vein behave, because under normal circumstances, the fistula size also change. If we put in a tourniquet, it enlarge a little bit. If you don't put in a tourniquet, then it shrink a little bit. So the sizing is actually very tricky.
And especially if you measure, one example is the just anastomotic lesion. Of course, the vein after the stenosis is not in the full expansion if it has a previous stenosis. And you treat it using this reference, and after the dilation, you can see the growth as we can see in the vessel. Sometimes 40% of in the lumen increasing, depending on the respiratory phase. Okay, let's do the last question. We need to move on. The last question, I will put them both together. So the question is there any evidence that scoring balloon have effect on drug delivery for DCB? And the other one is there any difference between a controlled dissection from scoring or cutting balloon versus POBA? Good question.
So, go ahead, Matteo, please. Sorry.
No, please, Leonardo, continue, please.
I think that my feeling is the scoring balloon can bring us a better vessel preparation during the DCB procedure, but we don't have evidence, a high level of evidence for this until now. But when we take a look in the scoring balloons papers, the results were similar, with DCB papers, even without the antiproliferative drug that we talked about this just a few minutes ago. And the second
Leonardo.
question, sorry?
Leonardo, I'd just in American Journal of Kidney Disease, a group of colleagues from China published in 2024 a randomized control trial, high pressure versus high pressure plus DCB versus only high pressure. And the result in AV fistula is impressive. At 1 year, the target lesion primary patency is around 80%. So yes, of course, we don't have any evidence, strong evidence, but this paper for me underline the link from a perfect preparation of the vessel with scoring or high pressure plus DCB. Why? Because in the novo lesion or in the novo with high number of cellular replication, the area of cellular rise is very deeper in the vessels. If you don't prepare the lesion, it's very difficult to calm the drugs in this area. So this is probably an answer to the different result with high pressure plus DCB versus only DCB plus POBA, naturally.
Do you see too many dissections during the access angioplasty?
So you know that I am a enthusiastic guy for the oversized use, and it's not common to see dissection, In general, we can see a intramural a wall hematomes, mainly when we are using oversized technique. And some experts, maybe more than 15 years ago, they used to think that this kind of hematomes was a bad thing during the vascular access angioplasty. But now When you do this kind of thing, and we have a hematoma on maybe a kind of dissection or something like this, when you perform a vascular ultrasound just 1 month after, it is unbelievable how the vein wall looks perfect. Yeah, I think that the reaction of the vein wall is completely different. The vein wall has the capacity to heal the wall, yeah, and to have a good flow after. So, and of course, I think that the balance between scoring and high pressure, it's nice, but I think that the section, it's not a huge problem. Just
Probably
my point of view.
the problem, I agree, Leonardo, the problem is the rupture of the vessel. With
Yes.
3 fixed elements, I think the micro dissection that we perform in the intimal hyperplasia help us to a perfect enlargement of the luminal area. With high pressure, with only a pressure or very hard, for example, the cutting with the blade, you perform a damage, a transmural damage of the wall of the vein, and a damage that we see commonly is the contrast medium around the vein wall. This is I think the difference is very difficult to speaking about the dissection in a wall vein.
Leonardo, can I follow up with your mentioning about the mural hematoma? So during the procedure, if you see a mural hematoma, a lot of the time the lumen is also will be narrowed down. Even if sometimes if we do another prolonged balloon angioplasty, the lumen will still be a bit narrowed down. So how you manage this condition in the during the procedure? How much will you accept that the lumen narrowing is okay, and then bring back and see how the patient afterwards?
Good question. So, it's not common in my practice to see mural hematoma and luminal reduce because of this mural hematoma. It's not common in my practice. But in this specific case, my suggestion is just to try to do a new angioplasty, like a endovascular tamponade, just to stabilize the wall, yeah, and of course make a new angiography. With the result, it's okay. We just follow. We used to measure the flow and the velocity with the Doppler ultrasound in this specific area. And another point that used to be useful is about the outflow. Sometimes we have this kind of restriction in the vessel wall because the outflow is blocked. Yeah.
It's important hematoma.
Yes, exactly. It's important to check if the outflow is open, just to organize the flow towards the venous outflow. Because if you have a restriction in the outflow, a block in the outflow, you will have a huge pressure in this stenotic area, in this hematoma wall, and because of this, we can have problems. And with this maneuver doesn't work, you can put a cover stent or maybe a bare metal stent just to organize the flow towards the outflow part of the circuit.
Okay.
Perfect.
Thank you.
We need to move on. So we're going to have the next presentation. It's going to be overcoming complex AV fistula stenosis, clinical experience from Singapore. Professor Jackie Ho.
Thank you. So, good day and evening to all of you joining this webinar from all over the world. It's my great pleasure to be here sharing some experience from Singapore. And I also really hope that you all can join in and leave comments and questions during this talk and after. So next. Well, we know that stenosis is really a major reason for the vascular access to become dysfunctional or thrombosis, and these access are precious to the patient. Next one. And then for the stenotic lesion, we of course can use both open as well as endovascular treatment, depending on the situation and of course depend on the expertise and resources. And tonight we will be more focusing on the endovascular. Next one. So I would like to really discuss with all of you with two cases. The first patient is a 76-year-old gentleman. He's relatively frail and staying in nursing home, a little bit obese, using the left BCAVF for already 6 years. And the BCAVF actually become aneurysmal. And when he come back to clinic for follow-up, it shows a mixed thrill and pulsation over the mid-arm fistula, high venous pressure, as well as a small dry scab that you can see in the clinical photo there. The brachial artery volume flow is actually quite high. So this is a situation that we also not uncommonly seen is a combination of slightly high flow, aneurysmal, and outflow obstruction. So I bring him in for the intervention. By the way, can click the next one. Yeah, so this is the arm angiogram, next one. And then here shows the upper arm as well as the cephalic arch that you can see a very clear stenotic lesion there. And next one. And apart from this cephalic arch to axillary vein junction high-grade stenosis, the central vein is patent. Okay, next. Okay, next. So my question to all of you is, how would you treat this lesion? Maybe I ask Professor Matteo Tozzi. I know of course, today the webinar is on scoring balloon, but what would be your choice or, yeah.
Thank you, Jackie, for your fantastic presentation. I don't know, in this case, I think I try immediately with a scoring, and depends on the recoil, I choose to maintain the treatment, so apply only a DCB with 1-to-1 sizing from scoring to DCB, for example, 7 or 8 millimeter for the cephalic arch. If after 5 or 10 minutes, the phlebography control showed a recoil, I stent. So I think the stent graft today is another choice, very, very important for cephalic arch. I don't like the primary stenting because we change the pathology. So the stent is not immune to the intimal hyperplasia. We speak about Leonardo and also with you in Patras about the intimal hyperplasia of the stent graft. So cephalic arch for me is scoring, first line treatment. And then I choose DCB or stenting.
Thank you very much. Okay, can I go back to the slide? So next one. So actually, I totally agree with you, Matteo. I think to put in a stent, we really have to think 3 times before putting something that is permanently inside the patients. And when the implant is in the long run, it might also have adverse reaction. Like the paper that Dr. Rob Jones published 3 years ago, having a very good retrospective review of 152 patients where there is a cover stent put in the cephalic arch, and it shows he shows over time there is actually quite a high percentage of the stent will eventually be migrating into, causing a grade 1 or grade 2 migration into the central vein. And these are also associated with higher incidence of central vein stenosis, which becoming more difficult for the patient in the long run. So I personally also have patients having this condition. Next. Like the top one is a Viaband stent. After 2 years implantation, initially it's a very nice position, but gradually migrated into the axillary vein and caused stenosis. And another patient also having a very complex axis, 3 months after the Illuvia stent implanted, it also have migration, and then 7 months eventually causing a central vein obstruction. Next one. So this is what I have been done. Next. The wire crossed the lesion. So I used the scoring balloon decutting. Next one. Very gradually inflate the pressure. Then we can see a very nice wasting of the balloon. So here have to inflate slowly, and also once going up to about 6 to 8 pressure, atmospheric pressure, I deflated and also rotate about 45 degrees. And inflate again. Next one. And achieve a full effusion. Of course, we have to bear in mind that this lesion, although looks very short, it can also easily having a rupture condition. So I totally agree, a cover stent to stand by is very important. But if not necessary, then better not to put in any stent. And then next, this is the completion angiogram. And you can see that actually the lumen opens up very nicely. Next. So the patient's fistula has a clinical response with a good flow. The brachial artery volume flow further increased to 1.2 liter with a very nice fistula waveform. And also very importantly, we instruct the nurses to needle away from the small skin lesion there. And once the pressure release, then the lesion will usually gradually improve. But of course, we also keep a close eye. Sometimes a surgical repair of the aneurysm might also be needed. Okay, next one. Thank you. So as we discussed in the early part of this webinar, there is very heterogeneous lesion for stenosis along the whole dialysis access circuit, because we have AVF, we have AVG, we have different location and different pathophysiology as well. Next one. But as Leonardo also mentioned, that actually very early work of Professor Terratola already showed that there is a higher percentage of access that is rather access stenosis that are rather resistant to the FH angioplasty pressure and require a much higher pressure. Next one. And this is the work of Professor Yu Zhengya from Beijing, China. In the resected specimens of the stenotic lesion of dialysis access, again, he discovered that there is a very high level of fibrous connective tissue, and explained why a high proportion of the access stenosis are actually more resistant and required a different strategy compared to the peripheral arterial disease. Next one. So I think the main direction of treatment for this resistant lesion are either non-compliance, high or even ultra high pressure, or using a focal high pressure concept. That means it doesn't need to be a very high overall pressure, but because of the pointing edges over the outer surface of the balloon, when it inflates, the pressure is force divided by the surface area. Because a very minute surface area, therefore the focal area of pressure will try to find a breaking point of those fibrous tissue and give a better expansion of the lesion. So in decutting balloon, it is actually having the concept of this focal high pressure as well as because of the material that it can be non-compliant as well as go up to the pressure of 20. So it's also having a characteristic of non-compliant and high pressure as well. Next. So I think which is more the non-compliant high pressure concept or the focal high pressure concept is more advantage to treat resistant dialysis access lesion. I think this randomized control study conducted by the Singapore General Hospital intervention radiologist as well as the vascular surgeon is a very nice study and published in JVIR in 2014. So among their AVF stenotic patients, they selected those patients that simple normal pressure balloon angioplasty cannot achieve a satisfactory outcome. That means more than 30% residual stenosis. And then randomized into high pressure balloon group, which is 36, and also next one. So in their study, they found that although the clinical success rate is the same on both sides, in fact, the primary target lesion patency rate at 6 months is much better over the peripheral cutting balloon side, which is the focal high pressure, which is about the double of the primary target lesion patency. And also the secondary patency is also more advantageous over the peripheral cutting balloon side. Next one. And this is the Kaplan-Meier curve. And you can see by the 6-month line in both primary and the secondary patency is more advantage over the cutting balloon. Next one. And then I will, as Matteo mentioned, this is a very large scale, although it's a single center retrospective study within 2 years from Beijing Haidian Hospital. It shows that either the scoring balloon itself or the scoring balloon plus high pressure balloon is able to provide a extraordinary good result of patency of TLPP of 78% by 6 months. And on the subgroup, the AVG group is also very good compared to the AVF, and there is no major adverse event. Next. And I would like to also discuss with all of you about this second patient. The second patient, she started dialysis long time ago. Now she's 70-year-old. She's a relatively short body build and the BMI of 30, using the left BBT for already 12 years. And over these 12 years, there are more than 20 interventions, angioplasty multiple times, and also stenting of the subclavian vein, as well as the fistula performed. And this time she come back for a drop in the access flow reported by the dialysis center. And the dialysis also showed that the patient has a very negative A pressure. And if you can see that the clinical picture shows the patient's arm. And next one is the ultrasound image. Next. Yeah. So this is AV anesmosis. You can see very close to the AV anesmosis. The just anesmotic area is also the A cannulation site has a high-grade stenosis. Next one. Longitudinal view, we can see that this is, of course, it's a JXA area, but it's also, unfortunately, the A cannulation area. So that is having a very disease condition. Next one. The brachial artery volume flow measure is about 600 in the clinic. Okay, next. So I would like to, if you see on the clinical picture, the blue color arrow side is the stent that being put in previously. So there is a short segment of JXA, then a segment of 2 centimeters of decent size fistula, and then further up is stented fistula. Although it also being cannulated successfully. So I would like to ask my friend Leonardo. So if you are to do an intervention for this lady, how would you choose your access site?
Thank you very much, Jack, for the question. I love the femoral vein access for the upper arm procedures. Yeah.
Okay.
We can position a long sheath in the
Yes.
subclavian vein or axillary vein and just do the procedure with a less amount of X-ray. And it's a so comfortable position for us vascular surgeon that used to
Right.
do a femoral procedure. So it's a good access for me. I really love this. Yeah. I don't know about Marcio and Matteo. Of course, for this case, we can use also radial artery, but it's not my preference, or jugular vein access, but I really prefer for upper arms AVF procedures to use the femoral vein access, mainly in basilic or venous graft anastomosis because it's just a straight way. Yeah.
How about Marcio?
I love the femoral access. I usually put the arms along the body so I can choose between the radial and the femoral access. I prepare the patient in this position, and there's one point to choose between them. Are you gonna use a large sheath or not? And the size of the radial artery and the position of the brachial bifurcation. So if you are a man with a huge radial artery and you are not expecting to use a stent graft, nothing, maybe I could choose a radial artery. But if a female patient, probably the radial artery is a thin radial artery, I would prefer to use the femoral access.
Right. Okay.
Vein or artery, Marcio?
What?
Vein access
No,
or
the
artery?
femoral vein, sorry.
Okay.
Femoral vein.
Next time I will try your suggestion. So yeah, let's go back to the presentation. So next, actually, her radial artery is quite small, only 1.7 millimeter and also calcified. So because before the BBT, she actually has a BCAVF, but was long time ago from both. So the distal brachial artery is actually quite decent size. It's 4 mm in diameter. So I started the procedure with a 6-French sheath. Yeah. And then subsequently, still need to upsize to the 7-French sheath. Okay, next one. So this is the angiogram showing that you can see that the stenosis is right next to the sheath because it's a distal brachial artery. So it's only like 1 centimeter into the distal brachial artery. And then we also see that it has a very diffuse stenosis along the stent that being put in previously. Next one. And then in the central vein, this subclavian vein stent also has been put in more than 5 years with recurrent stenosis. Yeah. But of course, the most important lesion for her is actually the inflow lesion. Okay, next one. So next, I started to use the decutting 7 mm by 40. So you can see that the lesion actually opened up nicely. Next one. And then also to treat using the same balloon to treat the in-stent as well. And next one. This is the ultrasound that you can see the vessel now is very nicely open. And then next one, also check the angio as well. Okay, next. So of course, at the same time, because now I increase the inflow, I don't want the patient to have a swelling upper limb later on. So I also treated the central vein with Alex Go 12 mm balloon. And then next. Okay, next. So the brachial artery volume flow increased to 1.6 liter per minute. And next. And the patient also have a good fluid regain. And again, of course, it's very important that the nurses should stop needling the area that is diseased. Otherwise, the effort will really waste very soon. So I need to move the A cannulation site a little bit more up to the middle of the arm, and also move the V cannulation site further up so that the two are not too close together. Okay, next. So, ladies and gentlemen, I think although these two patients, I don't think it's extreme complex dialysis access condition. However, I think each patient, they have a lot of unique things that when we consider an intervention, we have to consider according to patients' ESKD life plan, their medical condition, their body build, and also the access anatomy. So it's always, even when it seems to be a very straightforward case, there can be a lot of tricky points that we need to plan meticulously and thoughtfully. And we know that quite a large proportion of the stenotic lesion of dialysis access will be more resistant to simple balloon angioplasty, and then focal high pressure balloon, be it a cutting balloon or scoring balloon, actually showed favorable result for a resistant lesion. And it is a good armamentarium in dialysis access endovascular therapy. Having said that, I think we still have a lot of things that we don't know in dialysis access, and hopefully with further research and even collaboration in research that will find more answers with time. Thank you very much.
Congratulations.
And I hope that all of you can come and join us in Dialysis Access Synergy in September this year in Hangzhou, China. Thank you.
Congratulations for your presentation, Professor Jackie Ho. We're going to be there.
Yes, yes. Looking
Chinese
forward to
Yeah.
see you in
Yeah.
person.
Will be a pleasure
It'll
to
be
be
a
there.
pleasure.
Thank you very much for the invitation.
Thank you, thank
It'll
you.
be a pleasure. So we move on. I will present the next speech. I'm going to talk about planning vascular access angioplasty from clinical evaluation to complex endovascular intervention. This presentation is going to be organized the summary of what have been said before. So next, this is my conflict for this presentation. Next. So that's what happens when we create a fistula. We can see a change in the pattern flow of the vein. It changes from a low velocity, low pressure to a high velocity, high pressure flow. And of course, next, it creates some histological modifications, as we can see on the right, the thickening of the vein wall. Next, but sometimes that thickening acquires a pathological effect, as we can see next, with the negative effect on the vessel lumen. Next, and what causes we know it is the neointimal hyperplasia. It is our enemy. It is the reaction of the body to something that he doesn't want. He try to close it at all costs, and sometimes we need to deal with this. Next. But the neointimal hyperplasia is the problem? I don't think so. I think that the problem is what the neointimal plasia causes. And we have a central question: what problem are we solving? Are we solving just stenosis? No. We are solving access dysfunction, and it is not a histological or radiographic diagnosis alone. It's a clinical problem, and it is secondary to an anatomic lesion, and it requires a durable solution. Next. So how can we plan the procedure, the angioplasty? What should we consider? The first thing to consider is the clinical diagnosis. The next is the image. The third one, the planning, and the fourth, how to deal with the complex scenarios. Next. So the clinical diagnosis is a very important part because the best angioplasty begins in the patient evaluation. We can analyze the dialysis parameters, the patient complaints, and the physical examination. Next. The procedure starts before angioplasty. Good results need a good indication. That's something of the vascular procedures in the whole body. It's always the same. Next. So the hemodialysis gives us it's a kind of stress test done 3 times a week. So we need to use that information. Next. Next. So the physical examination, it is the one of the few parts of the body that we can use. We can watch, we can feel, and we can listen. So it is important to use. And the symptoms and the hemodialysis parameters define the urgency of the procedure. In many situations, the access have many lesions. We need to know which one needs to be treated. Defining what success means is very important because what do we have to provide? Maturation, increase the dialysis dose, symptom relief, access, because it can tailor your procedure. Next. It is important to keep that in mind. Angioplasty by time, but do not cure neointimal hyperplasia. So if you do it before the real need at the time, you not have the benefits of the angioplasty. Next. So what must be evaluated in the image? So we need to look at the arterial flow, all these parameters, the anastomosis, the just anastomotic segment, the cannulation zone, the venous outflow, and the central veins. Next. And what are the options to do that evaluation? The ultrasound, the fistulography, the CT and MR venography, and the intravascular ultrasound. But basically, next, we use the ultrasound because it's easy and it provides very good and valuable information. Next. So here are some examples of what we have to analyze. We need to measure the volume flow in the brachial artery. As we can see, we can analyze the entire venous segment of the fistula. We can see the lumen, we can see the wall thickening, the neointimal hyperplasia. Next, we can measure the velocity. Velocity is an indirect sign of stenosis, and we can measure the vessel near at the normal segment near the stenosis to decide which balloon, the size of the balloon or the stent that we should use. And of course, we need to come back, please. We need to look at the radial artery size, and we need to pay attention at the bifurcation of the brachial artery. If the patient has a high bifurcation and the anastomosis was done to the ulnar artery, the radial artery doesn't give you access to the fistula, so it can't be used. Next. So why should we do the image? The image is to turn the anatomy into a procedural plan. Before entering the room, you have to define that 5 decisions. You need to define the access route, which target lesion you need to treat, the balloon, the device that you're going to use, including the size, the end point that you're going to use it as a good result for your procedure, and the bailout plan if something gone wrong. Next. And as Matteo and Leonardo have shown, not all stenosis behave the same. The phenotype predicts balloon choice, inflation strategy, and the need for adjunctive devices. A recurrent lesion after excellent angioplasty may require a different strategy. You can't keep doing the same thing and expect different result. A poor initial result usually need mechanical correction before escalation. If you can't dilate the lesion properly, why should you use a stent graft? It's not the solution for the problem. Avoid escalating device before adequate vessel preparation and a clear anatomic diagnosis. It's much clear that the vessel preparation is a key point in every endovascular procedure. Next. So here we can see two different lesions. Here on the left, we can see a lesion that a classic neointimal hyperplasia pattern. On the right, you can see the wall thickening. It's a fibrosis around the vein. It's an extrinsic compression. It's not a growth inside the vessel lumen. And you can see that usually it occurs in different parts of and different types of fistula. The one is in the middle part of the cephalic vein in the forearm, and the other is a very tight lesion in the swing point. Next. And of course, that lesion, the behavior during the angioplasty is quite different. You can see in the top that you can dilate properly the balloon, but you can see a recoil after the balloon deflation. So you just keep doing dilation, it won't work. You need to use something, a stent graft or a stent to keep the vessel open. In the lower picture, it's a different situation. The balloon doesn't allow the good dilation of the vein. So in this case, the stent graft are not the answer. You need to improve the dilation, get a better balloon for higher pressure, or a scorinus or a cutting balloon, something to open that vessel. Next. So, of course, as any procedure, you need to check the pre-procedure checklist, the room. You need to check the ultrasound, the shift size, wire, balloon, stent graft bailout, from back to mid device if needed. Good planning makes complication visible before the first procedure. As I say, you don't wait until the airplane is flying to check everything. You need to check before it begins to fly. Next. And that is one of the most difficult parts, is to define the access route, the puncture strategy. You will need to start with the end in mind. So you can choose between antegrade, retrograde venous access, arterial dual access, or femoral vein access. Choose the route that lets you cross the lesion safely and image the whole concrete segment. Protect the cannulation zone. Use ultrasound guided puncture when anatomy is uncertain or prior procedures alter the access. Route choose should anticipate the bailout. If your access doesn't allow you to use the stent graft and the rupture is something that you have a high risk of rupture, so this is not a good access for this case. Next. So I will show you some case and why I decided to use. So this is one case that I use an antegrade venous access. Usually I use that kind of access in mature fistula, already used in where the segment has a proper diameter to put a sheath inside, get it out, compress, and don't have problems as stenosis of the vein. So here you can treat all the lesions. The vessel has a good size, and the antegrade recanalization is much easier because it's the direction of eventual valves in the vein. So it's much easier. When it's possible, I use this. Next. This is a case of retrograde venous access. This is more difficult access. You need to deal with the valves that sometimes make the recanalization difficult. But in this case, we have a just anastomotic lesion, so antegrade is not possible to treat. And we have stenosis in the middle, in the outflow. And this kind of access, I really like to do this when the patient has double outflow, as in this case, you can see the lower picture. You can use the cephalic or the basilic vein. So if you have problem, the outflow is not going to be fully compromised because of hematoma or stenosis. This third access is the arterial access. I reserve this access for unmatured fistula. You don't have any venous part that you can puncture in this case. So the arterial access is the only way, or the femoral access, as you can see in this case. And the next one, next, is the double puncture that I deserve for patients that I need to do thrombectomy. Of course, you need to do the thrombectomy in the entire length, and this is a good solution for this case. And in case of thrombosis, you don't know exactly where is the stenosis that caused the thrombosis. So you will need access to the double sides of the length, the double sides of the fistula. So this is a good access in case of thrombosis. Next. And the next one is the femoral vein access. I deserve this in immature fistula. Leonardo loves this access. You can treat things entire length of the fistula, and especially when I anticipate the use of stent graft, because stent graft require larger shifts that is not good to use in radial artery. Or I use this in case of high bifurcation of brachial artery and the anastomosis was done to the ulnar artery. So you will not have access to the fistula using the radial access. Next. So balloon size, I will not talk too much about this. Leonardo gave a very good explanation, but it's the most common mistake. Next one. Cutting and scoring balloon. When I use in resistant and fibrotic waste, short focal stenosis with inadequate expansion, recurrent lesions where better vessel preparation is needed, and as we discussed in previous, preparing a lesion for a drug-coated balloon or stent graft. What are the risks? Cutting balloon may injure fragile or total segments. The vasculation does not replace correct lesion diagnosis, and persistent recoil may require another solution. Next. So this is the decutting. I want to show some specific issues about this device. The first one is that it comes from 4 to 8 millimeters, a good size for peripheric AVF stenosis. The length is until 80 millimeters. The cutting balloon that we have is only 20, and the scoring balloons, they don't have high pressure. This one have the burst pressure of 20 atm, so it's better. The pressure is better than the other scoring balloons. Next, the shaft. It has 135 centimeters of shaft. It allows you to use the femoral access. It has a very good flexibility. I have used this in the arteriovenous anastomosis. It's the conformation is very good in this area. Next. And DCB, where they fit. The DCB is most rational after adequate vessel preparation. I will not give more details because the previous presentations provided that. So next one, I would get some considerations about the stent graft. It's a strong tool, of course. Sometimes you need to use, but it's a irreversible footprint. When should we consider to use this? Flow limit, rupture extravasation, elastic recoil after adequate angioplasty, recurrent lesions in selected patients. In AVG venous anastomotic, there is a lot of data supporting the use of this device, but we have to respect the footprint. We need to preserve future cannulation zone and surgical review options, and do not jail important outflow branches or future access vents. Stent graft can solve today's problems and define tomorrow's anatomy. Next. So now I will talk the last item, the complex scenario, managing rupture. The first thing when you have a rupture, do not remove access while bleeding or is uncontrolled. You can tamponade, pressure the anastomosis, and you will have time to use the balloon, put the stent graft if you keep the pressure, the compression in the anastomosis. You have time to reassess the hemodynamics and skin tension and evaluate the patient if you keep the compression in the anastomosis. That's something good that the arteriovenous access provides us. Stent graft choice must account for cannulation zone and future access options and document post-event cannulation restrict clearly. Rupture plan should exist before balloon inflation. Next. How can we prevent complication? We can prevent procedure-related complications like rupture, dissection, thrombosis, embolization. We need to pay attention to this. We need to pay attention in spasms and inflow compromise, stent migration or malposition. That's a catastrophe if you have a stent migration to the heart, so pay attention to that. And we need to pay attention to the access life-related complication, loss of cannulation zone, Jalen filter outflow vents, repeated ineffective angioplasty without change strategy. Next. Next. So when you have a recurrence, you need to pay attention to that loop. Early reintervention should teach you something. If the lesion recurs early, ask why. Wrong culprit, inadequate expansion recoil, cannulation trauma, central outflow problem, high flow physiology. You need to pay attention in that not only we keep repeating the angioplasty. Next. And what is the success? What we define as success? We have the technical endpoints as the culprit lesion treated with acceptable residual stenosis, no flow limiting dissection, recoil, rupture, or embolic complication. And this is a very good one. Improve the frill or brute. I always pay attention to the frill during the procedure. If the frill doesn't improve, the result will not be good. And we need to pay attention at the clinical endpoint. So success next in the next dialysis section, improve cannulation and pressure, symptom relief in venous hypertension, reduce the reintervention burden without sacrificing future access, move away from angiographic beauty as the only endpoint. Next. I will show you one case to show how I decide my plan. So it was a patient, a male patient, 79 years old. He was in hemodialysis for 7 months. He had a chronic kidney disease and secondary to the prostatic cancer. And he had a brachial basilic vein transposition in the right arm without maturation after 8 weeks. Next. So this is the ultrasound evaluation, the flow. Pay attention to this patient. He has a high brachial artery bifurcation. So the anastomosis was done to the ulnar artery and the flow was less than 500 millimeters. And we can see some areas of stenosis with the lumen of 1.3 millimeters in the most severe stenosis. Next, we can see the increase in the velocity, and we can see that the basilic vein has a small diameter, 4.8, and the axillary vein has a good diameter. Next one. So what was my plan? What was the access route? Femoral vein. I can't use the artery as access for this patient. Puncture the basilic vein with 4.8, I don't think is a good idea to double puncture. So the target lesion, what was the target lesion? It's clear. He has a basilic vein stenosis. What balloon device I was planning to use? A decutting 7 or 8 millimeter. In this first stenosis, my plan was not to use drug-coated balloon or stent graft, not yet. After, if the lesion has any recurrence, probably I will use the drug-coated balloon. And what is my endpoint? Maturation with a flow of more than 800 millimeters and less than 1.2 thousand millimeters per minute. Bailout, if something happened, rupture, I would compress the anastomosis, tamponade the balloon, see the result, and if needed, use a stent graft. So next. So that is the lesion. It is my access showing the long sheath in the axillary vein, as Leonardo told. Next one. So play the video, please. So here is the dilation. You can see there is a soft dilation. Usually when you use high pressure balloon, you see a sudden expansion of the balloon. In this case, you can see it's not a sudden, it's a smooth dilation. Use the decoding 8 with 80 millimeters balloon. Next. I did a second next. I rotate the balloon, did a second dilation, and that is the final result. A very good final result without any sign of rupture, only a small hematoma in the vessel in the lower third of the basilic vein. Next one. Next. So the patient used this fistula after 9 days. The volume flow in the ultrasound was 970 millimeters per minute. Next. So take home message: diagnose, plan, treat, and preserve future options. Do not treat images, treat access dysfunction. Vessel preparation determines adjunct success. Early device has a future access. Every device has a future access cost. Keep that in mind. And the endpoint is successful dialysis, not only angiographic appearance. Next. Thank you very much.
Marcio, a very comprehensive review of the strategy, and I totally agree what you said, that the procedure is well started before the angioplasty, and we always have to keep the end in our mind to do every of this procedure. Yeah, great presentation. Thank you very much.
Thank you. Thank you. I don't know if we have time to discuss anything, or if the audience want to make any question.
I see there are 2 questions.
Ah, nice.
One
If you
from
can-
Jimmy: what do you think is the difference between cutting and scoring on long-term outcome of fistula intervention? When might you use one over another?
Between scoring balloon and the other one? Sorry, I missed that.
Cutting.
Peripheral cutting balloon.
The problem of the cutting balloon is short. It's time consuming to do the angioplasty of the entire length, and the diameter is not so good. So if you have a focal stenosis, very good. If you have a long length, you will need to do it many times. And I love. I'm beginning the experience with the decutting. It's something new in Brazil now, but my experience is very good. I don't need to do too many inflations, 1 or 2 inflations. I get a proper result, and you can choose the length. You have the shaft to use femoral access, radial access, anything. So it's a very versatile device. I can use in many situations. So that's the main advantage of the deep cutting balloon over the cutting balloon, in my opinion.
Yeah, but I think
Probably.
for the long run, I guess it will really require more data to support. Decutting scoring balloon is a relatively new technology. So I think it will really need some more data. Like the retrospective study from Dr. Johnson's group, I think is showing a very nice result. But after all, it's a single center. So hopefully, maybe we'll see more like multi-center, and then eventually maybe randomized control study. Then we will have more answer to this question.
Yes, Jackie, I think the time is fruitful for a multi-center study about the cutting, but I think this new technology, relative new technology, is the evolution of cutting. In term, I agree with Marcio, in terms of diameter, length. If we see I don't know in Brazil, but in Italy, in Europe, we wait weeks probably for the larger diameter of the cutting for the central vein stenosis. So is a technology that covers all the possibility of treatment in the vascular arches. So I think is a beautiful era for this type of technology and allow a lot of treatment for our patients with very good outcome.
Right.
Yeah,
And also
so
Dr. Approver
so
asking about the scoring balloon in central vein. Any of you have experience using decutting in the central vein?
Today I don't have. I have experience with other scoring, but with maximum diameter is 10. I don't know if you know the focal force advanced scoring by Cook. So it's very useful for occluded central vein lesion to prepare for a stenting or for a bigger high pressure balloon. But for this reason, I think, and for the result that we have with this lesser diameter, I think the 12 or 14 diameter of decay for central vein was perfect for the central vein stenosis.
I have a question for you, Matteo. Do you think that, of course, the problem now for me here of using the decant and the score is the size, but do you think that do the pre-dilation cut and then use a high pressure balloon, it will be less damage to the vein than do using only high pressure, or you don't think it doesn't matter?
Correct, Marcio, is a possibility. But I think in my mind, for example, in central vein, we have two types of lesion. Occluded lesion with some thrombus, a very elastic lesion. In this case, it's necessary to use big balloon because the elastic part, the fibrotic part is very bigger in diameter. And second lesion, the diameter of vessel is very low, is completely collapsed for fibrosis of the adventitia. In this case, also a balloon like 9 or 10 run very well, and then after cutting with scoring, it's possible to use a larger high pressure. Is a strategy. So naturally, if you think it's possible to use a cheaper balloon for predilatation and then decutting larger diameter, for example, 12, and finished your preparation. So I think probably this way is most useful for reduce the damage. Leonardo.
I have a question for the panelists. We know that nowadays there is a kind of trend to treat venous graft anastomosis with cover stents. Yeah. Of course, different sites, different ways to treat these, but I think that it's a kind of trend in US, in South America. Do you believe that with this new technology and probably with a better mechanical angioplasty, better vessel preparation, do you think that DCB could be a good option to treat venous graft anastomosis, stenosis?
Leonardo, I don't know Jackie or Marco, but if I remember the paper published in 2024 by Kitru from central vein, the result of drug coating was good. Probably if you add a perfect mechanical vessel preparation with decutting, we achieve a a good result for DCB. I don't know. I don't have a final answer for central vein stenosis, but I think today correct vessel preparation and DCB and stenting is two different approach for the same way. Probably it's possible to choose for first line the DCB, and then after the recoil, for example, 1 year after, put the stent. The stent graft is not yes, it's a good option, but it's not the cure for the intimal hyperplasia, because we see probably every day the edge stenosis also in central vein. So it's mandatory to restart with new scoring, new high pressure, new DCB for treat the central vein. So in my mind, I think it's necessary to choose the correct sequences of device that follow the life of the vascular arches and the life of the patient. So probably this way is a possibility also for central vein.
And
get
if for
confused.
grafts,
sorry. Was you talking about central vein or graft? Venous
no,
graft?
I think that central veins would be my next question, but I think that Matteo answered the second question. But how about venous graft anastomosis stenosis? Do you think that we can go thinking in the same way, maybe try to do a vessel preparation with a decutting and after a DCB angioplasty? Because we don't have a high-level evidence about DCB in venous graft anastomosis stenosis. I think that there is a trend to use a cover stent in this area, but maybe with a better vessel preparation, DCB would be a good option. I don't know. What is your opinion about this?
Leonardo, I think you have a very good suggestion. Yeah, I think long time ago, when the stent graft is not really before the stent graft randomized control trial against the plain balloon, there was also papers on using the peripheral cutting balloon versus a simple balloon for the graft vein anastomosis, and showing that the cutting balloon arm is actually having a favorable result. However, at that time, the study was not adding on the drug-coated balloon in the study. So I think there is not yet any study that really compares a scoring balloon plus DCB versus a stent graft. So for me, actually, I always feel that if we have to put in a implant, it's actually should be the second choice, and as much as possible, leaving nothing behind is actually better. So I think it will be a really good idea to having a randomized study to compare the scoring plus DCB versus the stent graft.
There is one important thing to consider, Leo. If you look at the studies of comparing angioplasty to stent graft, if you look at the results, even the stent graft have bad results, like 50 or 60, 70% in 6 months. And if you look at the recent publications comparing stent angioplasty with drug-coated balloon, you can see that the angioplasty group have much better results, of course, because they are younger studies with better vessel preparation. I totally agree, but I don't think that anyone's gonna do that study.
Yeah.
It's a kind of holy truth that the stent graft is better. So I don't think that they will do. But I think to use this in one specific situation, but it's not so common, Leo. When you do the dilation of the venous anastomosis, usually in my experience, you see a lot of elastic recoil. So if you do preparation, wait 30 minutes, do a second one, and you don't see any recoil, okay. But who is gonna wait 30 minutes to see the recoil? recoil and decide between the DCB and or stent graft. So these are the problems, in my opinion, to create a study to analyze the behavior of these two devices in proper lesions. Because if you use DCB in elastic recoil, of course the result is going to be bad. So that's the problem to design a study to compare these two devices, in my opinion.
But at least maybe a single arm, some cases serious and analyze. But interestingly, Dr. Johnson's study, the AVG 6 months patency is actually around 75%, which is actually very high.
Yes, Jackie. I think the paper in renal failure by Lang Zhang, the analysis of graft treated with the decutting after more than 5 previous procedures, the target lesion primary patency is more than 80%. So is incredible in this field, and probably another point. Yes, correct. Organize a multi-center study for the evaluation of the decutting in graft vein anastomosis. I agree with Marcio. Probably one of the point in that increase the use of stent graft is the recoil in graft vein anastomosis. Most of colleagues don't see the recoil because immediately stop the angiography or the duplex ultrasound after 2 minutes of deflate the balloon. But after 30 minutes, 50% of graft have complete recoil. In this point, probably the stent graft is correct to utilize.
We are late for almost 1 hour.
Very late.
So everybody loves vascular access here. We can keep talking the entire day. And the audience, we have still the same audience of the beginning.
Yes.
Everybody interested in the conversation. That's a good sign. I would like to thank the DK Medtech for this webinar. All of you for the precious insights and our conversation. It was a very delightful time, and the audience for being here with us, learning more about this device. So if anyone else would like to say something, feel free.
Yeah.
Just thank all the guys. Sorry, Jackie. Just thanks all the guys, Matteo, Jackie, Marcio, and the Medical Tech for the invitation and for the meeting. It was amazing. Yeah, I love to stay in this meeting, and to share experience, and of course to learn too much with the other experts in the audience. Thank you very much for all.
Yeah. Thank you all the participants of this webinar, and thank you DK Medtech for organizing and also the invitation. I really enjoyed and learned a lot through the talks from all of you and all the discussions. Yeah, thank you very much.
Thank you all of you for discussion. I like a lot the discussion. And thank you to all the participants and DK Medtech for this amazing 2-hour discussion. Thank you so much.
Yes, and good day and also good evening to all the participants. Thank you.
Bye-bye.
Bye.
Bye, guys.
Thank you.
Thank you very
Bye, Wei.
much.
Thank you,
Bye-bye.
Jenny.
Good night, good
Thank
morning,
you.
and thank you very much. I'll see you guys
Have
again.
a good day. Bye-bye.
Bye.
Bye.
See you very soon, Marcio and Leonardo. And hope to see you again, Matteo.
Bye.
Bye-bye.